Welcome to this explainer, where today we are diving into a really heavy but incredibly important topic. We're going to break down two groundbreaking medical studies that reveal exactly how we can strengthen both our systemic and our personal safety nets to combat the suicide crisis. And look, while the subject matter is tough, the data we're looking at is actually super empowering. We're going to explore how we can identify risk way earlier, and even more importantly, how we can truly heal the individuals and families who are affected by it.
To start, we have to talk about a pretty stark reality: 30%. Let that sink in for a second. The suicide rate in the United States has risen almost 30% over the past 20 years. This single number represents a massive public health challenge, right? It really forces us to take a hard look and ask some tough questions about where our current safety systems might actually be failing. I mean, when a number climbs this consistently for 2 whole decades, it's a pretty clear signal that our standard approaches, they just aren't cutting it anymore.
So that alarming increase brings up a massive question. How exactly is our healthcare system missing the people who are most at risk? We often just assume that people in a crisis will clearly ask for help, especially if they're interacting with doctors or nurses. But as we're about to see, the reality of how suicide risk actually presents itself in a clinical setting is way more hidden and way more complex than you might think.
To get to the bottom of this, our agenda is straightforward. We'll cover the unseen crisis, look at screening everyone in emergencies, explore fixing the family safety net, and wrap up with a new standard of care. All right, let's jump straight into part 1, the unseen crisis. Get this. A whopping 8% of emergency department patients who come in for totally non-psychiatric complaints actually have unrecognized active suicidal ideation. Think about that. That number completely blows community estimates out of the water, which usually sit around just 3% for an entire year. These are people sitting in ER waiting rooms right now whose biggest risk factor is entirely invisible to the medical staff treating them. And that right there reveals a huge flaw in our systemic safety net. Treating clinicians are just completely missing the underlying risk because the patient walked in for a physical problem, not a psychiatric one. Whether they're there for a broken arm or a nasty flu, the staff naturally focuses on that chief complaint. The mental health crisis goes completely undetected, honestly just because nobody thought to ask.
Which brings us to Section 2, screening everyone in emergencies.
So how do we fix this blind spot? Well, that's exactly what the ED SAFE study tried to figure out. Researchers looked at a staggering 236,000 emergency department visits across 8 different hospitals to see if screening absolutely every single patient is even feasible. It's a massive undertaking. They wanted to know if you could bake suicide screening into the routine care of a chaotic, fast-paced ER without bringing the entire medical workflow to a grinding halt. To pull this off without slowing things down, they used something called the Patient Safety Screener 3, or PSS3. It's this brilliant, rapid 3-question tool designed to seamlessly bridge into a difficult conversation. They actually start by asking about depressed mood, just to ease into it. Then, they directly ask if the patient has had active suicidal ideation in the past 2 weeks. And finally, they ask about lifetime suicide attempts. It is super concise, completely standardized, and it literally takes just moments to do. And the results? Absolutely staggering. By using team-based quality improvements, the screening rate shot up from a mere 26% in Phase 1 to a massive 84% by Phase 3. These hospitals used continuous feedback, multidisciplinary teams, and they kept tweaking their protocols. Ultimately, they proved that yes, it is absolutely logistically possible to screen nearly everyone walking through those ER doors. Because they suddenly started screening so many more people, the detection of severe risk nearly doubled. Let me repeat that. It nearly doubled. Before this universal screening, the detection rate was hovering around 2.9%. With it, it jumped to 5.7%. When you extrapolate that out, it means thousands of people who would have just quietly slipped back into the community in severe distress were actually identified and given a real chance for intervention. But, that begs the ultimate question. Identifying the risk is really just the first step. What happens next? Catching someone in the safety net is essential, but it's only the starting line. Once a patient is flagged, especially when we're talking about a vulnerable teen, we need effective, proven treatments to actually help them heal. That leads us perfectly into Section 3, fixing the family safety net.
To figure out the what next, let's look at a second study that compared 2 specific approaches for adolescents: a specialized intervention called attachment-based family therapy, or ABFT, against the standard community referral process, which is known as enhanced usual care. This study focused on kids between 12 and 17 experiencing suicidal ideation. And they basically wanted to see if a family-centered approach could actually outperform just handing a youth a referral to a community provider.
Now, prepare yourself for this number, 2.9. That was the incredibly low average number of therapy sessions that suicidal teens in standard care attended before totally dropping out. Less than 3 sessions. Even with researchers actively helping them set up appointments and encouraging them to go, these highly vulnerable kids just were not staying in treatment. It really shines a light on a massive retention problem in our standard community care.
But compare that to 9.7. That was the average number of sessions attended by teens doing attachment-based family therapy. ABFT managed to keep families engaged for over 3 times as long as standard care. And look, when you're dealing with a suicidal crisis, just keeping the teen in the therapist's office is literally half the battle. ABFT clearly cracked the code on keeping them there.
So how does ABFT keep them coming back? It achieves this retention through 5 highly structured phases. It systematically repairs the family unit so parents and teens can truly hear each other. First, they do a relational reframe, shifting the goal from just managing symptoms to actually strengthening the parent-child bond. Then the therapist builds an alliance with the teen alone, and then the parents alone. All of this builds up to the reattachment phase, bringing the family back together to practice communicating, which eventually fosters the teen's competency and autonomy.
The real-world impact of this is just undeniable. Teens in ABFT experienced a far more rapid and much more sustained relief from suicidal thoughts compared to those getting standard care. The trajectory of suicidal ideation drops so incredibly fast during the active treatment phase. And the best part? The data proved that these benefits stuck around well after the therapy had officially ended.
Let's tie all of this together in our final section, a new standard of care.
By the end of 12 weeks of treatment, an unbelievable 87.1% of teens in the ABFT group hit the criteria for full clinical recovery. That vastly outperforms the 51.7% in usual care. The contrast is just night and day. Patients in ABFT were substantially more likely to show scores reflecting true recovery, meaning their suicidal ideation was reduced all the way back down to a normal, non-clinical range.
So, what's the big takeaway from all of this? Well, the ED-SAFE study essentially proved that implementing a universal systemic safety net is not only highly feasible, it's incredibly effective. By simply formalizing a 3-question screening process in emergency rooms, we can expose this unseen crisis and literally double our chances of catching someone before it's too late. It turns the ER from a blind spot into an absolute critical checkpoint. And on the flip side, the family therapy study proves that once we actually identify these at-risk individuals, structured, empathy-driven intervention can successfully rebuild their personal safety nets. We don't have to just hand out referrals and cross our fingers that they stay in therapy for more than 3 weeks. We have a literal blueprint in ABFT that keeps them engaged and actively heals the familial bonds that protect against suicide.
Which leaves us with one final, provocative question to ponder. If we already have the tools to identify the unseen risk, and the therapy's proven to actually heal the family, how quickly can we make this the standard of care everywhere? The evidence is right in front of us. We know how to cast the net in our hospitals, and we know exactly how to heal the family at home. The only question left is what is stopping us from making this a reality for every single patient.